is adrenal gland from the endocrinology. So I suppose everyone knows where adrenal gland is located. So when we took a cross section of adrenal gland consists of two parts. It has the outer part, which is known as cortex, and it do have an inner part, which is known as adrenal medulla. This outer cortex is further divided into three parts, and each of these three parts create different kind of hormones. So it is important to understand this, like different layer of the adrenal gland and what respective hormones each layer is creating, because you might get questions on this, and this is very easy. These are the easy marks. You can easily solve this as these and get some marks. So let's talk about the outermost layer of the adrenal cortex is the zona glomerulosa. As its name indicates, glomerulosa, that means it has something related to glomerulus. And where is glomerulus located? It is a part of the nephron, or you can say kidney. So it secretes a hormone which affects on the kidneys. And what is the name of that hormone? Is the aldosterone. So now, if you get a question like, which of the following hormone is secreted by the zona glomerulosa, the answer is very simple. Glomerulosa means something which has to do with the kidneys. So the answer is aldosterone. Then the middle part of the adrenal cortex, or you can say the intermediate part of the adrenal cortex, is known as zona fasciculata. And this part plays a very important role. It creates a very important hormone, which are glucocorticoids, or cortisol, you can say. Then the innermost layer of the adrenal cortex, it is known as zona reticularis, which secretes androgens. And this is very important because androgens are very important in terms of male and female sexual reproductive health. So androgens are very important. They have a big influence on the reproductive system. Then the inner part, which is adrenal medulla, it secretes catecholamines. So it has some different origin. Even why it is secreting catecholamines, why it is not secreting a hormone which is cholesterol based. Why it is so different? Because when we look at the embryological development of the adrenal gland, these two parts derive from different layers. So that's why they have different origin. So they have different functions, and they secrete different category of hormones. Aldosterone, glucocorticoid, and androgens, all of these are cholesterol-based hormones, whereas catecholamines are different. So important catecholamines are epinephrine and norepinephrine. So let's talk about adrenal medulla, because this is very simple and it is not that extensive as compared to adrenal cortex. Okay, so let's talk about the structure of a cholesterol molecule, because all the hormones which are secreted by the adrenal cortex, they are cholesterol made. So it is important to understand the basic structure of cholesterol, and you might get a picture of this molecule, and they may ask you what structure is it, what molecule is it, or there are many questions they can ask you from the cholesterol molecule. So let's have a look at this cholesterol molecule. The formula of cholesterol is C27, H46, and 1O. Why C27 and why it is important to remember the carbon levels of the cholesterol molecule? Because when we look at the different hormones which are made from cholesterol, they are different in the carbon numbers. So we can identify a hormone on the basis of carbon number. So again, the normal cholesterol molecule, which is not yet metabolized or processed, has 27 carbon atoms. And what else we can see in the cholesterol molecule? It has 4 rings, A, B, C, and D. And there are different questions, like let me extract some questions from the cholesterol molecule. Please do let me know in the chat box at which carbon level the hydroxyl group is attached. Look at the picture and solve this question. My question is, at which carbon number the hydroxyl group is attached in a cholesterol molecule? Okay, that's good. It is C3. My next question is, how many number of rings are there in the cholesterol molecule? Yes, Dr. Melna, that's correct. Okay, why I'm asking separately this question, because maybe you may get a question in which they ask you which of the following is not true about the cholesterol molecule. So in order to answer that, you have to cover a bit about cholesterol molecule, or maybe they will ask you which of the following is correct, or which one of the following is not correct regarding the cholesterol molecule. So that's why this is very easy to remember. Again, yes, 4 is the right answer. So what are the high yield points from the cholesterol molecule? It has 27 carbon atoms. The formula is C27H46O. Hydroxyl group is attached at the carbon number 3. Okay, I have another question. Where is the hydrocarbon tail is attached on the cholesterol molecule? My question is, at which carbon number the hydrocarbon tail is attached on a cholesterol molecule? Yes, C17 is the right answer. Here, this one is a hydrocarbon tail. And why did I ask this question? Because when the further hormones from the adrenal gland are going to form from the cholesterol, this tail could be cleaved. So you should be know from where this tail would be cleaved. It is at the carbon number 17. So what else we are left with from cholesterol molecule? Yes, we are left with one exceptional question. Okay, between which carbon number the double bond is present in a cholesterol molecule? Yes, C5. Okay, my question is, between which number of carbon atoms in a cholesterol molecule double bond is present? I'm asking about the double bond. Did you see any double bond at the carbon number 1? There is no double bond there. It's between 5 and 6. Here you can see between the carbon number 5 and 6 double bond is present, and that's the only double bond in the cholesterol molecule. So these are the high yield points from the cholesterol molecule. Again, why I put so much emphasis on cholesterol, because this is very important for all the male and reproductive hormones. So we have a crystal clear understanding of the structure of this molecule. So let's move on to our next slide. So now you can understand the importance of these carbon levels. Okay, your job is to remember which of the hormones consist of 21 carbon numbers, and which of the hormones have 19 carbons, and which of the hormones have 18 carbons. So remember progesterone, deoxycorticosterone, aldosterone, and cortisol. These are the adrenal hormones which have 21 carbon numbers in their structure. So these are 21 carbon steroids, you can say. 21 carbon steroids or 21 carbon hormones, they are progesterone, deoxycorticosterone, aldosterone, and cortisol. And here is another SPA. Progesterone is the precursor for others in the 21 carbon series. So progesterone is the first hormone in the steroidogenesis, which comes from the cholesterol molecule and further give rise to other cholesterol or adrenal hormones. So remember, if you in the exam you will ask by this question that which of the following hormone is the precursor hormone? So the answer is progesterone. In a while, we will talk about steroidogenesis, and I will tell you like this progesterone comes from which molecule. For now, remember 21 carbon steroid are progesterone, deoxycorticosterone, aldosterone, and cortisol. Then let's talk about the 19 carbon steroids. And now you can imagine how these 27 carbon numbers are, how they are processed and cleaved and converted into these hormones by the adrenal gland. And the process is known as steroidogenesis. Okay, then 19 carbon steroids are androgens and testosterone. These androgens are later on converted into testosterone in the testes. Then 18 carbon steroid is estrogen. So how do I remember this? Usually boys are taller than girls, so that's why testosterone have one more carbon number, 19, and the girls are usually younger than boys, so or smaller than boys, you can say. So they have less number of carbon atoms, which is 18. So 19, 18 remember in sequence. Am I clear? Try to memorize these points here because all of these are SPAs and they are important, and they are, honestly, if you remember here, they are very easy, and later on you just have to give a quick revision. So try to memorize with me at the moment, and that's why I'm repeating all these points again and again, so that it would retain in your mind. Okay, so this is your steroidogenesis. Now you can see how that C27 cholesterol molecule, it is when it is enters into the adrenal gland, how this is further processed. The process is known as steroidogenesis. And why it is steroidogenesis? Because it is giving rise to the hormones which are steroid based. So there is don't try to memorize all this process of steroidogenesis. Just remember the high yield points. Let me tell you, if they ask you what is the first step or the first molecule which is formed in the steroidogenesis, that is pregnenolone. And now you can see how this pregnenolone gives rise to progesterone, which is 21 carbon hormone, and this further gives rise to all of the rest of the hormones of which are steroid based in the adrenal gland. So remember these 3 points in the sequence. What they can ask you, all the hormones, or maybe they ask you particularly about estrogen, maybe progesterone, testosterone, cortisol, or aldosterone. All of them have the same precursor molecule, that is cholesterol. If that is not in the option, the precursor molecule will be pregnenolone. If pregnenolone is not in the options, then progesterone is the precursor molecule of all the hormones. So try to remember in the sequence, because in the question, the options may vary. You may don't find the option of cholesterol there, then you have to choose that accordingly. So it is important to remember in the sequence, cholesterol molecule and from where that cholesterol molecule comes from. It may comes from your diet. It may comes from the lipid bilayer of the cell membrane. So whatever. We have the cholesterol in our body, and it is important to have some good quality of cholesterol in our diet, because now you can see how these important hormones are gonna form from the cholesterol. So remember cholesterol, it is further under the action of cholesterol desmolase, This is an enzyme which is the first step in the steroidogenesis. Cholesterol desmolase converts the cholesterol into pregnenolone. Please remember the name of the enzyme as well. This is also high yield, and pregnenolone is a precursor for progesterone, and progesterone is precursor for the rest of the hormones. Is everyone clear till now? Because I understand this is a bit tricky topic, and I really don't want to mess with your heads. Okay, and please again memorize with me. Okay, now we have progesterone. Okay, under the action of 21 beta hydroxylase, and soon we will study about the 21 beta hydroxylase deficiency. So now let's understand that here as well. What is the function of 21 beta hydroxylase enzyme? It converts progesterone into 11-deoxycorticosterone, which further converted into corticosterone, which then forms the aldosterone. So you may skip these points. Just remember progesterone is important. This 21 beta hydroxylase action is important if we want to have aldosterone in our body. So what happens in the patients who have 21 beta hydroxylase deficiency? So tell me, is that aldosterone would be there or not? Please tell me if 21 beta hydroxylase enzyme is deficient and it is not able to process progesterone into further process. So does the body is able to make aldosterone? No, there would be no aldosterone then if there is no enzyme. So that means the process is not working fine. So there would be a deficiency of aldosterone. Yes. Similarly, if we look at this sequence, this is the synthesis of cortisol hormone. And please tell me from which part of the adrenal gland cortisol comes from? Yes, fasciculata. We are actually we are studying biochemistry at the moment. Okay, so cortisol. Okay, we have another metabolic disorder, which is autosomal recessive 11 beta deficiency, or we have 17 alpha hydroxylase deficiency, and we also have alpha beta hydroxylase deficiency. So now tell me, if a patient have alpha beta hydroxylase deficiency, would that person have enough cortisol in their body? Okay, yes, there would be no cortisol. Similarly, if a person do not have 21 beta hydroxylase in their body, you can see here 21 beta hydroxylase is also playing a role. So if a patient is having 21 beta hydroxylase deficiency, does that patient have 11 cortisol, have cortisol in their body? The answer is again no. Even if a person have alpha beta hydroxylase deficiency, there would be no aldosterone. So in a nutshell, in the patients who have 21 beta hydroxylase deficiency or 11 beta hydroxylase deficiency, there would be less aldosterone, or there would be little or no cortisol as well. So what happens if these precursors are not processing in this pathway? What happens in 21 beta hydroxylase deficiency or 11 beta hydroxylase deficiency? All these precursors would be shunted into androgen synthesis pathway. So as a result, the patient, the baby or the newborn have excess amount of androgens. And that is the clinical findings. We will discuss in a while what are the clinical presentations of a patient or the babies who are having 21 beta hydroxylase deficiency or 11 beta hydroxylase deficiency or even 17 20-lase deficiency or 17 beta hydroxyprogesterone deficiency. So there are many autosomal recessive conditions. So is everyone clear now, or do I need to repeat anything? If you have no question, please do let. Okay, good. Is it clear? So let's move on to the next topic. This is adrenal medulla. Now we are done with the adrenal cortex. Glomerulus are done. We know how this hormone aldosterone is being synthesized in the cortex. We are done with the zona fasciculata hormone, which is cortisol. Now we know that how steroidogenesis give rise to the cortisol level. Zona reticularis. Now we know how androgens are being formed by through the steroidogenesis. Now let's talk about the medulla. If you look carefully at the medulla, they have some different cells. These are you may say cuboidal cells, and these cells are known as chromaffin cells. And why I'm putting emphasis on these chromaffin cells, because some of the tumors may form here. So have an idea. So these are the chromaffin cells which secrete catecholamines, that is epinephrine, norepinephrine, and dopamine. These catecholamines are water soluble, they are fast action, they derive from the tyrosine. Now compare both. Adrenal cortex hormones synthesized from cholesterol, but adrenal medulla catecholamines derived from the tyrosine. These chromaffin cells or adrenal medulla is innervated by preganglionic sympathetic fibers, which act through acetylcholine neurotransmitter. So again, these are all the points I'm discussing right now. There are the question in the exam. They are the high yield points. So please try to remember. If you in the exam they ask you which of the neurotransmitter is present in the adrenal medulla, or which of the neurotransmitter is responsible for the production of catecholamines in the adrenal medulla, the answer is acetylcholine. Is everyone clear? Is everyone clear about the neurotransmitter, which is acetylcholine? It is responsible. What happens? These sympathetic fibers create this acetylcholine here in the adrenal medulla, and as a result, these chromaffin cells produce epinephrine, norepinephrine, and dopamine, and they are derivative of tyrosine. We have many pictures on steroidogenesis in the coming slides, so don't worry. Okay, since we have discussed about the normal structure, steroidogenesis, and the different parts and the hormones of adrenal cortex and medulla, now let's talk about some endocrinopathies. So the important endocrinopathy from the adrenal medulla is, which is important for your exam, is a pheochromocytoma. It is a neuroendocrine tumor that grows from the cells called chromaffin cells. So again, now imagine how these chromaffin cells are important. They secrete epinephrine, norepinephrine, and dopamine, and they have the tendency, there is a chance they might get tumor, which is neuroendocrine tumor. And since they are producing catecholamines, so what happens if any of the tumor occurs here, the patient may may produce increased amount of epinephrine, norepinephrine, or dopamine, and those would be the clinical features of that patient. So what are the clinical features of the pheochromocytoma? Are headache, palpitations. Why palpitations? Because the patient have high catecholamines, and we know these catecholamines are released during fight or flight response. So we all experience this. If we saw a big lion in front of us, we got that palpitations. So that is our neurotransmitters are working at the moment. Marked by pounding, flirting, or beating rapidly. Hypertension, yes, because of again those catecholamines. Pale appearance, or you can simply imagine this is some overactivity of your sympathetic system. Sweating, tremors, or shaking. Investigations are we go for the 24 urinary phenyl mandelic acid or metanephrine or normetanephrine. These are the screening method. And in order to localize the tumor, we go for the CT abdomen. Management. Okay, in the exam, they would not ask you about the management of pheochromocytoma, but I have added this for your information. the definitive treatment is a surgery. And before we go for the surgery, we give the patient 6 weeks course of alpha blocker in order to control those hyper overstimulated sympathetic symptoms. So another SBA which is asked in the recalls, they ask you about pheochromocytoma is a part of which multiple endocrine neoplasias. So please look at this table and give me the answer. Pheochromocytoma is a part of which multiple endocrine neoplasia? 1 or 2? Yes, 2 is the right answer. Pheochromocytoma is a part of multiple endocrine neoplasia 2. The rest of the tumors or the rest of the pathologies or neoplasias are primarily hyperparathyroidism and medullary carcinoma of the thyroid. So I have added both of them. You may have a read later on, both about MEN1 and MEN2. Okay, now let's talk about we are done with the adrenal medulla and all the high yield points. Now let's talk about the adrenal cortex. So these slides are a bit extensive. So what I suggest you, whenever you're doing endocrinology, try to spend some time on this subject. Why? Because this is a high yield subject. There are many questions from the endocrinology and they are a bit tricky. So if you just cram those SPAs, you would not retain that for a long period of time. So I recommend that always, whenever you are studying some pathologies of any hormone, try to understand the normal function of that hormone. Why? Because if you understand the normal function of any hormone, you can easily pick out the pathologies. So don't memorize this. Just have an idea like how these hormones are being synthesized, what are the axes of these hormones, and what are their normal functions. Once we are done with that, then we will start the pathologies. Okay, any of you, please let me know, all of you are clear about positive and negative feedback mechanism. Do you have a clear understanding what is negative and what is positive feedback mechanism? Okay. Dr. Rebecca. Okay. Okay, so negative and positive feedback mechanism. Whenever you're starting any subject, try to have a crystal clear understanding of the basic concepts, because these two words we frequently use throughout the endocrinology. So let me give you a concept of negative feedback first. So imagine you are hungry and you started eating something. Now your tummy is full. So what would you do? Your stomach sends a signal to the brain that I'm full, I don't need much food now. So what your mind do? It would send you the signals that please stop eating. So this is your negative feedback. Let me portray this in the endocrinology. For instance, if there are many negative feedback mechanisms. For example, if we take insulin, why we need insulin in the body when there is hyperglycemia, and that hyperglycemia triggers the insulin release. Similarly, your hunger triggers you to eat something. So once the insulin job is done, it stabilizes the hyperglycemia. Now, do you want to get hypoglycemic? Yes or no? Definitely no, you don't want to get hypoglycemic. Now the insulin job is done. So at that very moment, this insulin, through some mechanism, sends the signals to the hypothalamus that my job is done. There is no need to produce more insulin in the body. So, and as a result, there would be no more insulin produced by the hypothalamus or the pituitary gland, or from the pancreas. from the pancreas. However, it is started all the way up from the hypothalamus. If we study the hypothalamic pancreatic axis, somehow just remember, if we don't need any hormone more, it is sent to the signals to the hypothalamus that no more hormone is needed. This is your negative feedback mechanism. Am I clear to everyone? Okay, so this is simple. Again, just imagine if you are hungry, yes, you take food. When you are full, your stomach sends the signals to the brain that I'm full, and your brain sends the signals back, stop eating. So this is your negative feedback. This is not the stomach and eating example is the negative feedback. Basically, it is all about the endocrinology and the hormones regulation. So all of the hormones in the body, they are mainly controlled by the negative feedback mechanism. The positive feedback, what example should I give you? Okay, if we, all the girls should agree with me. We girls are by nature, we are like that. The love is never enough for us. The more we get the love, the more we want the love. So same goes with the positive feedback mechanism. For example, it is seen in the process of, during the menstrual cycle. There is a high level of estrogen, and once that high estrogen level is achieved, it sends more signals to the hypothalamus that I need more estrogen. And that estrogen that leads to further in order to go for the ovulation. So this is your feedback, positive feedback, which is mostly seen during the menstrual cycle by the estrogen. Am I clear? Okay, so remember these concepts throughout your endocrinology. You are studying any hormone regulation. Please do consider this positive and negative feedback mechanism. Now let's start our adrenal cortex hormone. So let's talk about glucocorticoid secretion. I'm only going to discuss the high yield points. It follows a circadian rhythm. By that means cortisol levels are highest just before waking up, around 8 a.m. in the morning, and lowest in the evening during the midnight, around 12 a.m. So just remember, cortisol levels are highest before waking and lowest in the evening. That's it. Now let's talk about the hypothalamic control of corticotropin releasing hormone. Again, starts from the hypothalamus. It secretes corticotropic releasing hormone, which acts on the pituitary gland to secrete anterior pituitary to secrete an adrenocorticotropic hormone. And this ACTH is responsible because it acts on the adrenal cortex to produce further hormones. So what is the axis? Hypothalamus secretes corticotropic releasing hormone, which acts on the anterior lobe of the pituitary gland to secrete adrenocorticotropic hormone. Let's move on. Let's talk about the negative feedback control of cortisol. Cortisol inhibits the secretion of cortico-releasing hormone from the hypothalamus and the secretion of adrenocortico hormone from the anterior pituitary. So again, now yes, that when the body needs cortisol, yes, it is being produced by the hypothalamus corticotropic releasing hormone, ACTH. That ACTH acts on the adrenal gland, particularly on the adrenal cortical fasciculata, secrete cortisol. But once there's enough cortisol in the body, this cortisol sends the negative feedback to inhibit the secretion of corticotropic releasing hormone from the hypothalamus. If that is inhibited, automatically there would be no more ACTH and automatically there would be no more cortisol. So this is your negative feedback mechanism. And here lies the pathology, you may say, or the mechanism behind the dexamethasone suppression test. It is based on the ability of a dexamethasone, a synthetic glucocorticoid, or cortisol, you may say, to inhibit ACTH secretion. In normal person, low dexamethasone inhibits or suppress ACTH secretion. If that follows a normal negative feedback mechanism, consequently cortisol secretion. In person with ACTH secreting tumors, low dose dexamethasone does not inhibit cortisol secretion, but high dose dexamethasone does. In person with adrenal cortical tumors, neither low or high dose dexamethasone inhibits cortisol secretion. So for now, just read this slide, and later on when you are revising this topic, please try to memorize these findings and try to understand how what is the mechanism of dexamethasone suppression test. So apparently, or in a nutshell, in normal people, if we give the dexamethasone suppression, if we do that, it normally follows the negative feedback control of the cortisol or the glucocorticoid. But in if the person has some pathology, that would not follow this normal negative feedback cortisol. So what are the actions of cortisol? We are talking about the glucocorticoids, which comes from the adrenal fasciculata. It stimulates gluconeogenesis. Okay, now imagine cortisol is your stress hormone. So whenever we all experience stress in our life, so now imagine when we are in stress, what type of things our body need at that time. So what those things which our body needs at that time, it is provided by the cortisol. So these are the functions of the cortisol. So what it do, it stimulates gluconeogenesis. That means it increases the glucose level, because during stress we need glucose. And we used to take ice cream when we are facing any stress, so we need glucose. That means, so it is provided by the cortisol by the process of gluconeogenesis. It also decreases glucose utilization and insulin sensitivity of adipose tissue. It increases lipolysis, which provides more glycerol to the liver for gluconeogenesis. It also has anti-inflammatory effects. Prostaglandins and leukotrienes are involved in the inflammatory process response. Glucocorticoids have anti-inflammatory properties by inhibiting the formation of precursor arketonate. No need to remember much details. Just remember the normal high yield points, the normal function of the glucocorticoid hormone. Okay, for now we know we need glucose during stress. Anti-inflammatory effects, it is evident from the fact that we use corticosteroids for the many inflammatory conditions. And we also use corticosteroids in the autoimmune conditions when we want to suppress the immune system. So that means it has a normal function of suppression of the immune response. Then the next function is maintenance of vascular responsiveness to the catecholamines. So it upregulates the receptors on arterioles and increase their sensitivity to the vasoconstrictor effect of the norepinephrine. Thus, with excess cortisol, the blood pressure may be high. So we are done with the normal function of the cortisol. Now let's talk about the aldosterone, and we are well familiar with this hormone. So basically, it is not that a much control under the ACTH. It is mainly under the influence of regulated by renin-angiotensin system and by potassium. So mainly, if you get a question in the exam, they may ask you what is the main regulator of the aldosterone hormone. So what would be your answer? Please tell me. What is the main or the stimulator, you can say, or the regulator of the aldosterone hormone? It is regulated by renin-angiotensin system, but mainly the most potent stimulator for the aldosterone secretion or regulation is potassium. Yes, if you find that option, Ras is correct, but as far as I remember, I have seen some recalls. There is a one recall which is frequently repeated in which there was no option of renin, but they do have the option of potassium, along with calcium, no sodium, and other molecules. So remember, potassium is the most potent regulator of aldosterone secretion. Okay. So there are many high yield points from endocrinology is very important, I must say. All of these questions are your SPS. So they ask question from the renin-angiotensin aldosterone system, and these are some high yield points. They may ask you about the renin. What is renin? It is an enzyme catalyze the conversion of angiotensinogen to angiotensin 1. So please memorize this whole line or this whole slide if possible. For instance, they may ask you, angiotensinogen is converted to angiotensin 1 under the action of which of the following? So the answer is renin. Or in the other way around, they may ask you, renin is responsible for which of the following? Conversion of angiotensin 2 into angiotensin 3, maybe angiotensinogen to angiotensin 1, or maybe they give you some other options as well. So answer is, and renin is responsible for the conversion of angiotensinogen to angiotensin 1. Then now angiotensin 1 has been formed. Now how this would be processed further? This one is now converted into angiotensin 2 under the action of this enzyme, and they may ask you, where is this process is taking place? Please tell me, where does in the body angiotensin 1 is being converted into angiotensin 2 under the action of ACE or angiotensin converting enzyme? Yes, perfect. Lungs is the right answer. And where, from which structure the renin comes from? Yes, kidney is the right answer. Yes, juxtaglomerular apparatus more precisely. Yes. Okay, so what would be the next step? Now we have angiotensin 2. Okay, angiotensin 2 acts on the zona glomerulosa of the adrenal cortex to increase the conversion of corticosterone to aldosterone. Aldosterone increases, now it is now acting on the kidneys, on the collecting tubules, on the distal convoluted tubules. It increases sodium reabsorption, thereby restoring extracellular fluid volume and the blood volume to the normal. So do you know when this renin angiotensin aldosterone system would get activated? And why the nature has designed this system? What is the purpose of renin angiotensin aldosterone system in the body? And why these enzymes and molecules are being messed around? What is the purpose of having RA system in our body? Yes, to maintain blood volume. But at what particular conditions it gets stimulated? Yes, correct. Decrease blood pressure. You can take the example of hemorrhage. In case of hemorrhage, this would be, or maybe during the very low blood volume, but just take the example of hemorrhage so that you would remember. When there is low blood pressure. Yes, okay, let's move on. Hyperkalemia increase aldosterone secretion because we know potassium is the most potent stimulator of aldosterone. So yes, if there is more and more potassium in the body, there would be more and more aldosterone. So that makes sense. Okay, actions of aldosterone. Remember carefully. If you remember these 3 points, you can solve any pathologies related to this this part of the adrenal gland. So what are the normal functions of aldosterone? It increases sodium reabsorption. It increases potassium secretion. It increases renal hydrogen ion secretion. I'm repeating this again. Now imagine aldosterone increases renal sodium reabsorption. That means if it reabsorbs sodium, the more water would be absorbed in the body. So just imagine a person is going through hemorrhage and the body is trying to hold the body fluid back, and once the RAS system is get activated, yes, aldosterone is being produced. And what is its section to retain body's volume, and how it would do that? It would reabsorb the sodium more and more, and along with sodium we know that water follows. So if this aldosterone retains sodium, it would retain water and it would help to increase the blood volume. One function done. Then everything has a price. if the body is retaining sodium, the body has to pay something. This aldosterone, if aldosterone is picking up sodium more and more, it has to give back something. And what is giving back? The aldosterone is giving up on the potassium, so it increases the renal excretion of potassium in exchange of sodium. So everyone is selfish, even at the hormonal level, everything is selfish. We have to, this is all about give and take. So increased renal hydrogen ion secretion. So along with potassium, this hydrogen would also be secreted. Now let's talk about the pathologies. Now, if you have crystal clear understanding of the normal functions, just reverse those normal functions, and you are done with the diagnosis of these pathologies. So let's talk about primary adrenocortical insufficiency, which is your Addison disease. Now, if in the Addison disease, we know there is no adrenocortical hormone. So what would happen? The normal function of these hormones would be reduced. So now decrease all the normal functions or reverse all the normal functions. So it is mostly caused by autoimmune destruction of the adrenal cortex. The most common cause, if they ask in the exam, is the autoimmune disorder. It is characterized by decreased adrenal glucocorticoid, decreased androgen, decreased mineralocorticoid. Since these hormones are decreased, so ACTH would in return increase, because now the pituitary and hypothalamus are trying to attempt to compensate that loss. So that's why ACTH is increased. Hypoglycemia, because we know the normal function was to increase glucose level, but now there is no cortisol, so there would be no further formation of glucose, so hypoglycemia. Weight loss, hyperpigmentation due to increased ACTH level, decreased pubic and axillary hair, hypercalcemia, hypertension, hyperkalemia. Why hyperkalemia? Because aldosterone is no more working, it is no more excreting potassium, so as a result, it is accumulated in the body. Hyponatremia, because it is not getting reabsorbed by the adrenal, by the aldosterone, so that's why we are losing sodium. So it would lead to hyponatremia. Metabolic acidosis, due to this hyperkalemia, it would lead to hydrogen ion retention, which leads to metabolic acidosis. Then we have eosinophilia and lymphocytosis as well. So what is secondary adrenocortical insufficiency, which occurs when the pituitary gland is not able to make enough hormone ACTH? And how we can differentiate primary from the secondary? In secondary, there would be no ACTH, and if there is no ACTH, there would be no hyperpigmentation. So this is a classic difference. In primary adrenocortical insufficiency, there is increased ACTH because the body is trying to increase that loss of hormones. So there would be hyperpigmentation. But in secondary adrenocortical insufficiency, the problem is within the pituitary gland, so there would be no ACTH. Yes, there are all the findings of the adrenocortical insufficiency, but there would be no hyperpigmentation. Is everyone clear about the Addison disease? Or if you have any questions, you may ask me. Or if you are getting bored, please do let me know. I will precise the lecture as well. Okay, no questions? Okay, good. Because I was wondering, I'm just teaching and nobody is giving any response. So I thought everyone is sleeping. Okay, so now let's move on to the Cushing syndrome. Now imagine in Addison disease, there were no normal aldosterone hormone or cortisol hormone, but in Cushing disease, there is an excess of cortisol hormone. So now we know the function of cortisol. We need cortisol during stress, and in stress we eat ice cream, so we need glucose. So what the cortisol would do, it increases the gluconeogenesis through various means. Then we know that when we treat the patients who are having some immune disorders. We give corticosteroid to suppress the immune system. That means that is a function of cortisol. Another important function is it has anti-inflammatory effect, because we give corticosteroid during treatment of many infectious diseases. So these are all the normal functions. So what happened in the Cushing syndrome? We know there is an excess. So all these functions, the normal functions, would be amplified. Okay, so what happens when these cortisol androgen levels are raised? Yes, if they are raised, they would be decreased ACTH, because now the body thinks that yes, we need that more hormones, so there is nothing to do at the moment. It same goes here. If you kept on eating, and you didn't tell your mind that I'm full, you will keep on eating. So similar cases here. Like there are a lot of cortisol androgen levels, but there is no suppression. So ultimately, there would be decreased ACTH level because of the persistent increased level of these cortisols and androgen levels. Hyperglycemia, because the normal function is increased glucose, so hyperglycemia, it is exaggerated. Increased protein catabolism and muscle wasting. Why? Because this the normally cortisol use gluconeogenesis, and it utilizes different resources like protein and everything. So that's why if there is more and more glucose from gluconeogenesis, there would be protein catabolism. And once there is protein catabolism, there would be muscle wasting. Central obesity, because of the fat redistribution. Poor wound healing, virilization of women caused by elevated levels of androgen as well, hypertension, osteoporosis, elevated cortisol levels cause increased bone desorption and strias on the tummy. Ketoconazole, an inhibitor of steroid hormone synthesis, can be used to treat Cushing disease. So here you can see all the clinical features a person might have who have Cushing syndrome. There could be emotional disturbance in large. Why emotional disturbance? Because we need cortisol in order to regulate our emotions or distress as well. So it may affect our emotional mood. It do have some mood effects. Okay, but important, moon phases, osteoporosis, cardiac hypertrophy due to hypertension, buffalo hump, obesity, which is mostly pronounced on the lower part or the central part of the tummy. Why? It is because of the fat redistribution. There could be adrenal tumor hyperplasia, which could be the underlying cause. Abdominal stria, amenorrhea, muscle weakness, purpura, amenorrhea. Why? Because of the disturbed androgen levels, purpura, and skin ulcers. So these are some of the clinical features of the Cushing syndrome. Now let's compare what is Cushing disease and what is Cushing syndrome. Okay, I won't recommend you to memorize all these slides. I have just made them so that you would know the normal functions. So once you know the normal functions, solving these Cushing syndrome or Addison disease would become a lot easier. So your task is to remember these points, this table. Cushing disease and Cushing syndrome. What is Cushing disease? It is mainly a disease which is ACTH dependent, characterized by increased level of ACTH in the blood, and mainly caused by pituitary adenoma. Why pituitary? What is the pathophysiology behind that? This pituitary adenoma, we know whenever there is a cancer, there is a risk of increased production of particular hormone which is produced by that organ. So in case of pituitary adenoma, what happens, there would be more and more ACTH level production. And once there is ACTH, increased level of ACTH in the blood, so we termed it as ACTH dependent, and it is always endogenous. But when we look at the Cushing syndrome, it does not depend on the ACTH level. It is classically characterized by increased level of cortisol rather than increased level of ACTH. Why? Because it does not depend on ACTH. Why it does not depend on the ACTH? Because the cause lying behind the pathology in the adrenal gland itself, maybe adrenal adenoma, bilateral adrenal hypertrophy, adrenal carcinoma, and steroid treatment. It may be endogenous and may be exogenous. So in the exam, you may ask this question: what is the most common exogenous cause of Cushing syndrome? So what would be your answer? What is the most common cause of Cushing syndrome? What exogenous cause of Cushing syndrome? Yes, steroid treatment or exogenous steroid. Yes, pharmacological steroid use. Yes. Okay, what is the most common cause of Cushing disease? Okay, this is a point I want to make that clear. Yes, pituitary adenoma is the correct answer, because endogenous cause is always if in the question they ask about you Cushing disease, if you had listened me carefully and same mistakes you do in the exam, so always make sure, are they asking about the disease or the syndrome, and then go and choose your answer. If they ask you about the Cushing disease, that means it is something which is related to pituitary gland rather than the rest of the pathologies. So if they ask you about the Cushing syndrome, then the answer is exogenous steroid treatment. Then let's now, so far we have done with Addison disease, which was adrenocortical deficiency or insufficiency. Then we talk about the Cushing disease, which is the excess. And now let's talk about hyperaldosteronism, which is also known as Cohen syndrome. And now imagine all the normal functions of the aldosterone hormone. And now you can easily conclude that what would be the finding in the Cohen syndrome, because now all the normal functions of the aldosterone are being exaggerated. So this is how you can understand endocrinology in a better way. So it is caused by aldosterone secreting tumor. It may lead to hypertension, because we know the normal function of the aldosterone, it comes and play its role when there is hypertension in the body. Because why hypertension? Because if there is more and more aldosterone, there would be more increase in the sodium absorption, which leads to increase in the extracellular fluid volume and blood, and which leads to hypertension. So this is very simple. Hypokalemia, because yes, if there is more and more sodium absorption, in return, the aldosterone have to pay the price, and that price is potassium. It is losing potassium, so leads to hypokalemia. Then if it loses potassium, along with potassium, the hydrogen ions would also be being secreted, and the loss of hydrogen ion means there is alkalosis. So it would lead to metabolic alkalosis and decreased renin secretion, because there is no more stimulation for the renin, because we know renin angiotensin system comes in and play the role when there is hypertension in the body, and in this particular case there is always hypertension, so there would be decreased renin secretion. So I think now everything makes sense to you. Okay, your job from this presentation is to memorize at least these tables. These are your SPAs. It would cover all of your Addison, Cushing, and Cohen's in a nutshell. So what is Addison? If you quickly want to revise these three together, Addison is chronic primary adrenal insufficiency. That means there is no adrenal hormones. Cortisol and aldosterone deficiency. If there is no this cortisol and aldosterone, the normal functions of cortisol and aldosterone would be loose. Patient may have hypertension, hyponatremia, hyperkalemia. Tests are 9 AM cortisol and synchatin test. In Cushing disease, there is excess of these hormones. So the clinical findings are reversed. You can compare both. Here we have hypertension, here we have hypertension, weight gain, and diabetes. Then the test for Cushing disease is dexamethasone suppression test, and we know that the mechanism behind dexamethasone suppression test, we are classically assessing the negative feedback control of ACTH and the hormones, or 24-hour urinary cortisol. Then if we look at the Cohen's, say aldosterone excess, so the normal function of aldosterone has been exaggerated, which leads to hypertension and hypokalemia. Hypertension, why? Due to sodium retention. Hypokalemia, why? Because aldosterone is paying the price of that sodium, which is your potassium, so leads to hypokalemia, along with your metabolic alkalosis. But here you can see there is hyperkalemia, so imagine along with potassium is the hydrogen ion, so it may lead to metabolic acidosis. What are the tests? Yes, we know that aldosterone is a part of renal aldosterone system, so we assess the ratio, we do the saline suppression test, or we can do fludrocortisone suppression test as well. So this is a table you have to memorize. Now let's talk about 21 alpha hydroxylase deficiency. Now, if you imagine we are moving from outwards in the adrenal cortex to the inwards, and for now we have discussed the endocrinopathies from the zona glomerulosa and zona fasciculata. Now we are at zona reticularis, and we know that zona reticularis is responsible for androgen synthesis. So now we are discussing the pathologies of androgen synthesis. So the most common cause of 21 hydroxylase deficiency, what was the question? Let me remember. There was an SPA in which they asked directly about, I think, the most common cause of congenital adrenal hyperplasia maybe. So the answer is 21 alpha hydroxylase deficiency. And what is the second most common cause is your 11 beta hydroxylase. Yes, second most common cause of congenital adrenal hyperplasia is the alpha beta hydroxylase deficiency. So remember both of them. Most common is 21 alpha and second most common is 11 beta. And we have discussed that how these are being, what is the pathophysiology behind that. If we don't have 21 alpha hydroxylase deficiency, I have that steroidogenesis. If there is what we have, let me see, where is that? Yes, here we have 21 alpha hydroxylase deficiency. Here we don't have this enzyme. What would happen? There would be no aldosterone. Here also 21 hydroxylase enzyme plays a role. If that is not there, there would be no cortisol. So what happens? All of these precursors would be shunted into androgen pathway, and as a result, there would be very increased level of these androgens, androstenedione and testosterone. So this is all about 21 hydroxylase deficiency. So the baby may present with ambiguous genitalia. Why? Because there are excessive androgens, which may lead to clitomegaly. Females may present with urogenital sinus due to high levels of circulating adrenal androgens. So there is no need to remember all of these. If you have time, you can read if you want to have a better understanding of this disorder. However, just remember 21 alpha hydroxylase deficiency is the most common cause of congenital adrenal hyperplasia. And what are the clinical findings? The baby may have ambiguous genitalia. And what pattern it follows? It is autosomal recessive disorder. Okay. It may, we know if there are more and more androgens, they may lead to virilization. And here you can see how she's a girl which have excessive hair, excessive pubic hair. And same goes if there's a boy, he's also having excessive pubic hair. So now let's talk about alpha beta hydroxylase deficiency. Yes, if there are no alpha beta hydroxylase, there would be no cortisol. Again, there would be less aldosterone. However, aldosterone level may be normal because it is also controlled by 21 hydroxylase. However, again, here all these precursors are shunted towards sex hormone synthesis, and the person or the baby may have more androgens. And this would lead to infertility. Okay, now let's talk a bit about ambiguous genitalia in the sequence, since we are discussing that. So have a look on this topic. When we suspect ambiguous genitalia, what is the definition of ambiguous genitalia? So the answer is when the external genitalia do not appear completely male or completely female, we termed it as ambiguous genitalia. Then when to suspect, there is a criteria. When micropenis is there, that means if the stretched penile length is less than 2.5 centimeter in a term newborn, that means that baby have ambiguous genitalia, or there may be asymmetry of labioscrotal folds, there may be penis with bilateral non-palpable testes, there may be unilateral cryptorchidism with hypospadiasis. So all of these are pointing towards ambiguous genitalia. Here you can see this is a picture of micropenis, and the stretched penile length is less than 2.5 centimeters. So this is ambiguous genitalia of a baby who has 21 beta hydroxylase deficiency. So this is a table. You may remember in cases of a baby boy who have genetic makeup of 46XY genotype, the conditions which may lead to ambiguous genitalia is partial androgen insensitivity, there may be complete androgen insensitivity, there may be 5-alpha reductase deficiency or gonadal dysgenesis. So these are the conditions which lead to ambiguous genitalia in a male baby or a baby who have genotype XY. When we look at the 46XS, in the females, this ambiguous genitalia may lead to virilization, but in males, it leads to undermasculinization. That means undermasculinization means they don't look like a male, and virilization means development of male-like structures like increased bone, muscle strength, and virilization, or the pubic hair, etc. So the cause in the 46XS genotype of ambiguous genitalia is again 21 hydroxylase deficiency. We have discussed that. In utero exposure to maternal androgens will lead to ambiguous genitalia and gonadal dysgenesis. Then there is another category of ambiguous genitalia, which is ovotesticular disorders, basically. That may be seen in true hermaphroditism. In what happens there, both testicular and ovarian tissues are present in the gonads. So it is true hermaphroditism that the baby may have both testicular and ovarian tissue, and it may lead to ambiguous genitalia. Is everyone clear up till now, or do I need to repeat anything? Okay, good. So I think this is the last slide. This is about evaluation of ambiguous genitalia, and this is a high yield slide. Basically, all of these slides are high yield. There are many questions of endocrinology are covering from this presentation. So let's have a look how we can manage or investigate of a patient or a baby who have ambiguous genitalia. Now imagine you are working in obs and gynae, and you deliver a baby, and the nurse came to you and asked you the baby's genitalia are not yet cleared. So now you assess the baby. You know the criteria now, that what is the criteria to categorize a baby with the ambiguous genitalia. So what would be your next step? You will check the karyotype for sure. If that is 46XX, that means she's genotypically female. Then what questions would come to your mind? Like, if she's a female, then she's supposed to have uterus. If there is no uterus, that means it is something related to Mullerian agenesis. If the uterus is present, that means it is not Mullerian agenesis. Now we need to rule out some other things. For example, we know that the most common cause is 21 alpha hydroxylase deficiency, so start the workup for that. So 17 hydroxyprogesterone is the marker we use to diagnose the patient of 21 alpha hydroxylase deficiency, and this is your SPA. Like if you want to you want to find out, does this baby with ambiguous genitalia have 21 alpha hydroxylase deficiency, you need to measure this level of 17 hydroxyprogesterone. Is everyone clear? Please remember 17 hydroxyprogesterone is the marker which we use to diagnose a baby with ambiguous genitalia, to diagnose that she is having 21 hydroxylase deficiency. Is everyone clear? This is high yield, and I know this topic is pretty confusing, so that's why I'm putting so much emphasis on this. 17 hydroxyprogesterone. Okay, some students may think if a baby have 21 alpha hydroxylase deficiency, so we need to measure that in order to diagnose the patient, but that's not the case here. If we want to diagnose or we want to rule out 21 alpha hydroxylase deficiency, we need to check 17 hydroxyprogesterone level. So what would be your next step? Now you have ordered this investigation. It may came back normal. It may came back increased. So what happens if it came back increased? That confirms your diagnosis of congenital adrenal hyperplasia. This topic is done. If that came back normal, then you need to find out further things because you already ruled out melanogenesis. So what would be your next step? You may do ultrasound, ovarian testicular ultrasound. You may order the biopsy to find out other pathologies. There may be true hermaphroditism. That means the baby may have bisexual gonads, which is also a cause of ambiguous genitalia. Then in other case, you may assess maternal virilization. That means there is a chance, since she is a female baby, there is a chance she has been exposed to the maternal androgens during pregnancy. So you need to assess that as well. And for that, you need to assess the maternal virilization disorder, like how much levels of androgens the mother had, which affected the baby. So this covers all about ambiguous genitalia. So these are just a demo question. However, I have discussed all the high yield SPAs from the recalls during this session. So take this as your test. Regarding cortisol, which of the following is true? You have 45 seconds to answer this question. Okay, I got only one answer. Yes, B is the right answer. Well done. Yes, B is the right answer. Plasma concentration increase in pregnancy with estrogen. It does not cross placenta in significant amounts. Plasma concentration is peak in the morning. These are some of the high yield points from the cortisol. Okay, your next question is which of the following disorder is correctly matched to an appropriate diagnostic test? Please be quick. You have only 45 seconds, out of which 20 seconds has already been passed. Okay, your correct answer is B. In cons, we do saline suppression test. What is cons again? It is abnormality of aldosterone excess. Clinical features are hypertension, not hyperkalemia. Why? Due to increased sodium retention and increased potassium excretion. And the tests are renin aldosterone ratio, saline suppression test, or fludrocortisone suppression test. So thank you so much for bearing with me so far. If you have any question, you may ask me, or otherwise I would end the session. Welcome, Dr. Melna. I hope now endocrinology made more sense to you. Yes, Dr. Ramya, we can do a session on embryology. Yes, definitely. Sure. Okay, for those students who were asking about, I have seen some messages. They were asking about some exam-oriented material and the SPAs. Yes, the good news is here. We are currently running over one of the course, which is our Power Hour course, in which we are discussing all the high-yield topics along with the SPA practice. And soon we are going to arrange a workshop on which is a 15 days workshop, and which we are going to discuss all the important last 5 years past recalls in those 15 days. And yes, definitely, while discussing those SPAs from the past recalls, we will address all the relevant high yield information along with that. And trust me, that's a trigger start to your preparation. It would help to summarize and your all the MRCG-1 curriculum, and before the exam, you will feel more confident if you cover all the high yield topics along with the SP practice from the last 5 years recalls. If any of the students have inquiry regarding our workshop, which we are going to arrange in coming days, and if you have inquiries regarding our currently running courses, you may contact our coordination team. Or if you have any queries, we are more than happy to help you.